Recording in progress.
Hello. First of all, thank you for the invitation to be here with you today. And I hope I can share some different points of view about the titanium and zirconia implants. Today we talk about titanium versus zirconia implant based on a long-term evidence. But today I want to talk about the allergy and hypersensibility. This is my focus on this lecture. My name is Regeane Kaniak, and I be in Brazil. I work with dentistry, I think more than 24 years. And for at least 15 years, I use titanium implants on my clinic. You have to know about this. I insert titanium implants in my father and my mother. I use these materials a long time in my practice. I must be insert more than thousands implants in patients, but today I choose not work with the titanium anymore. Today I only use zirconia implants on my practice because my choice is in dentistry. I always look for the better treatment for my patients. I specialized in acupuncture also and integrative techniques to try to give for my patient a better heal and a better moment in the pre-operation and post-operation. And that path lead me on this way right now. Some kind of integrative dentistry, and some choices I made about materials and techniques, try to give my patients a different experience. In Brazil, I also a speaker of ceramic implants of Straumann, and I am a teacher about osteomonology, maxillomandibular osteomonology. In Brazil, I wrote this book, Cavitational Osteonecrosis and Jawabone, with Johann Lechner, is a great researcher, a German researcher. You will hear about this on this lecture. So let's do. So the first point, I want to start with some affirmation. Titanium allergy can be detected in dental implants patients, even though its estimation prevalence low, 0.6%. This is the most truth. And most of the colleagues I know use this to validate the use of titanium. Okay, titanium has a really low prevalence of allergy. It's not a problem with titanium. Everything's okay. I don't want to be against this article, because in this article, the colleagues studied more than 1,000 of patients to get this point of view. But today I want to talk to you about another point of view, because you have to know that 0.5% are 100% of my patients. Who treat these patients, this 0.5%? Maybe that number of the patients, it's more than you imagine. So let's talk a little about this. Okay, so this is our article of start. We have in the 2008 that article with this conclusion that the prevalence of allergical or the implants, it's a really low 0.5, and in 2020 we have another article use that same information. So okay, we have to consider this. It's a low allergy, but I studied a lot about osteoimmunology, and I have to do this point of view for you. Let's talk a little about osteoimmunology. First, we have to remember what is the success criteria in implant dentistry. If our patients have occlusion and aesthetics, is okay. If our patients have no periimplantitis, is okay. If our patients has bone stability or integration, is okay. The patients will happy, the dentist is happy also. But another point to consider it is the immune reaction. Immune reaction in the bone marrow, Why I talk about this? Oh, in 2000, Aaron Ishoy introduced the concept based on the strong links that have been found between the bone and immune system. Osteoimmunology is an interdisciplinary field which can give us answers about complications on osseointegration and reactions to titanium also. The immune system and bone cells have a conjoining heritage on stem cells, or that means the bone marrow stem cells. They share signaling pathways and influence each other permanently. After a bone injury, immune cells, especially macrophages, are present throughout the healing process. And we have here organizing the body's defenses against the pathogens and discharging a complex variety of effectors to regulate the bone remodeling. So the concept of osteoimmunology today is used not only in the dentistry, but used also in medicine and other, all the time we have these connections between bone and immune system. And that explains a lot of things to me. We have the critical role of the immune system and the osseointegration process of the implants. And for you, it's really common, we talk about osseointegration when we have the mechanical stability of our implants within the bone tissue. We have that implant stability and support bone remodeling happening. But the other concept I want to consider is the myelointegration, the bone marrow microenvironment. And here we have the bone marrow stem cells, we have the bone marrow, we have the cancellous bone, we have here the heterogeneous cells populations. And we have here the periimplantite bone niche, and we have the bone marrow niche also. And we will have the crosstalk between bone and immune system. So for our implant to become integrated and myelointegrated also, it needs to trigger an osteoformative response around the titanial surface as both cortical and cancellous bone levels. Most of the times when the implantologist opens the surgical area and see that beautiful cortical bones, it seems to us everything is okay. And then we have that stabilization of our implants, it seems to be okay. But maybe we have some kind of immune response happen in that bone marrow also, okay? Let's talk more about this. But cancellous bones is organized in trabecular, surrounded in bone marrow space. You know that. But in turn, the bone marrow is the natural reservoir of bone marrow stem cells. Why I talk about this? Because we have some transdifferentiation happen. We have cellular transdifferentiation and interference with surgical outcome. We have inside that cancellous bone the BMSC, the bone marrow stem cells. That stem cells which can mature in different kind of cells, chondrogenic, myogenic, osteogenic, or also adipogenic cells. That kind of alteration we have in the FGOJ with prevalence of adipogenic cells. Okay, sorry. We have more adipogenic cells than osteogenic cells happening in that bone. And that differentiation, differentiation, will happen on the receiving the appropriate sign. We have a differentiation that's bone marrow stem cells happens by stressors, by physiological needs. So we can have some changes happen inside that bone. Changes occurs on the transcription profile, on the cellular metabolism, and also cellular morphology. So we have to consider this when we study osteoimmunology. Multifactorial inputs, including mechanical stability, aging, and metabolic disease, will define the fate of these progenitor stem cells, leading to establishing either an optimal or adverse environment for our osseointegration. We can have here these cells maintain a stable bone mass and then bone homeostasis throughout life by differentiating to the osteoblastic lineage, able to secrete bone matrix. Besides, bone marrow stem cells can differentiate in the chondrogenic and the adipogenic lineage also. We have some different stimulus to these cells to happen this differentiation and create that environment for our osseointegration on the bone implant interface. Besides the stromal component, bone marrow hosts the hematopoietic cell lineage. Between it, both myeloid and lymphoid progenitor cells give rise to the monocyte, macrophage, osteoclasts, cell lineage, and T cells, respectively. Lymphocytes T. We will talk a lot about lymphocytes in this moment. So, especially bone marrow, myelomonocytic cells will support the population of monocytes, can differentiation into macrophages with the defensive environment or residing in the bone marrow. Just a moment. Okay. I like a lot to show that slide in my presentations because that slide remember us the importance of the regulation of an inflammation. Every injury in bone starts with an inflammation, but we have to control that inflammation. The control of inflammation is essential to osseointegration But when you have an excessive inflammation, can lead to implant failure or can lead to a chronic alteration. Is sometimes that kind of chronic alterations persist in our practice because the chronic alteration don't hurt. Sometimes we have some little infection. In the body regulate this. The patients can survive with a teeth with a chronic inflammation. When you have an acute inflammation, it's different. It hurts. The dentist needs to resolve that thing. But the chronic inflammations, well, in Brazil happens a lot. The patients leave that teeth with that problem, leave that implant with that problem if are a chronic problem. So quickly here, the innate immunity. We have the physical barriers, we have the mediate response, we have a non-specifically and a quickly response. That happen in the acute phase. When the body don't resolve that inflammation, that problem, we have the adaptive immunity acting. And here, I have to put this to show to you the difference between the allergic and hypersensibility. Because when you have allergical, normally we have the activation of lymphocytes B. And here we have the slowly response, we have a highly specific response. We have here production of antibodies. But sometimes our immune system reacts activating the lymphocytes T. And here we have a cellular immunity. We have a signaling of the cytokines and chemokines to activate cells. We don't have antibodies when you have the activation of lymphocytes T. It's two different ways of our immune system reacts. This is important to put you in the same thinking I can show to you. We have, of course, after that acute response, that innate immunity, adaptivity immunity, if the body don't resolve the inflammation, we have the chronic inflammation. And one thing common in the pathologies of bone marrow involving chemokine happens in chronic inflammation. I show this. So the immune response can involve some degrees of hypersensibility to titanium particles, can involve the hypersensibility to ions released from the implant surface or alloys surface with our components of the crowns, of the rehabilitation, also the different alloys we have in the mouth. And we have the immune response when you talk about that kind of chronicity of unresolved inflammatory response. And here we have the chemokine activation. Here we can have the bone marrow disease in jawbone also. So titanium particles are immunogenic, not allergenic. This is a little tricky and different thing to happen because when you talk, okay, no problem, the patient has only 0.6% of allergic reactions to titanium. Okay, but maybe your patient can have an immunogenic reaction, not allergenic. So when you have the immunogenic, we have that kind of activation that I'll show you before in the slides before. In the process of inflammation, in the process of the immune adaptive inflammation, and the process of the activate that bone marrow stem cells with that kind of signaling. So this is a little different, and maybe is a little difficult to measure with texts and exams also. But okay, let's come back to that slide. So in that article, that author related the production of interleukin-1 and TNF-alpha by mononuclear cells after exposure to dental implants. And here we don't have that usual allergic reactions. Here we have immunological inside that bone marrow. We have, it's common in the acute inflammation. We have TNF-alpha, interleukin-1, interleukin-6. There are types of cytokines released in the acute inflammatory. So the stimulation of interleukin-1 and TNF-alpha production by these materials suggests that they are not physiological inert, and that production may contribute to less favorable also adaptation. So we have to consider this. Another point of view here is about a literature review on ions, the dissolution of titanium and alloys in implant dentries. And here we have some points to consider. I don't know if you already see, but in my practice, I remove a lot of titanium implants. It's common in my clinic, have to remove that titanium implants. And that remaining treats of the implants, that titanium deposits of particles in the bone after the titanium removal, it's a really very common. And here you can see the healthy bone and the multiple titanium deposits, and also the fibrotic and degenerative adipose tissue surround that particles. Because here we have in the first time an acute inflammation, try to solve this, and second time a chronic inflammation with a differentiation of these cells and transformation of we expect a healthy bone into adipocyte tissue, like FGOJ. So the titanium and the alloys provide improve the physical properties along with good resistance against corrosion and acidic and saline environments. Outright, titanium alloys highly resist the corrosions because of the stability of the oxide layer of titanium. They are known to be vulnerable to the corrosion attack also, especially when the inert layer of the titanium oxide is breached. So we can have this happen or remove it and not able to reconstitute itself. The result is an oxidation process with the release of corrosions, products, and metal ions to the peri-implant hard and soft tissues. I'm pretty sure you also see when you remove your crown or your screw of the implants for some kind, you see that oxide, the metal oxides. You don't have to clean the inside that crown before to install again. So it's very common for us see that kind of oxides. And we have a lot of different materials in our clinic. So here is a little schematics of titanium degradations process and ion release. The first one, the ions release, activate the macrophage and have a foreigning bone giant cells reaction. We have here also the activation on B, lymphocytes B, that kind of reactions who leads an allergenic and antibodies can happen, and this 0.6%. Or we can have here the activation throughout the ion links to the macrophage, to the T helper, the lymphocytes T. And here we have other kind of cascade, inflammatory cascade happen. So here we have, when you have that increase of ion release, we have increase of osteoclastic activity, we have a decrease of osteoblastic activity. Titanium implants and silent inflammation in jawbone, a critical interplay of the dissolved titanium particles and cytokines, TNF-alpha and CCL5 and overall health. So this is another article, show that bone surround an implants with changes with that particles. And here also you can see that yellow tissue call here FGOJ, fatty degenerative osteonecrosis in jawbone. We have that differentiation of that tissue. We have a not healthy bone. And here we can see in our picture a higher level of RANTES. We have interleukin 1, interleukin 6, interleukin 8, but we have here a lot of expression of RANTES. And when you have that kind of titanium particles, we can activate that process of osteoclastis. Can lead to perimplantitis or can lead of production of RANTES. And when you have RANTES, what is RANTES? Quickly here, we have RANTES is a chemokine. It's a chemokine with chemotaxis and effects and immune activation. RANTES regulated on activation normal T cell. That means regulated by lymphocytes T. RANTES is also known as CCL5. It's produced by cytotoxic T lymphocytes, and that kind of chemokine is really common to have be surround our implants when you have an FGOJ. Here it's an example that patients of mine, the patients has osseointegration, but she related pain after the implant insertion. And the colleagues who did this is everything okay, your X-ray, it's okay. But when I see, when I studied the bone density surround that implant, I found that chronic inflammation here. And you can see the radiolucity area and the osseointegration area. So maybe our patients can have the hypersensibility, not allergenic, happen because of immune system. And RANTES is also related a lot of immunological diseases. So let's talk hypersensibility. The hypersensibility to titanium and particles and ions release, like immediate, mediate, type 1 is a quickly EGA dependent. We have the symptoms here. We have the vascular permeability, we have the muscle contraction, we have the anaphylaxis, we have atopic dermatitis. We have here the antibodies, the immunoglobulin E. We have these antibodies produced by the immune system. We have symptoms related by patients. That kind of sensibility are the 0.6%. But the other type of hypersensibility are the type 4. That kind is can happen 48 to 72 hours after, mediated by lymphocytes, Th1 and cytotoxic lymphocytes. And within dental implantology, the type 4 hypersensibility reactions could be more prevalent, because here the patients cannot feel anything. Maybe starts an immunological process, but the most of the parts, the dentists and the medical doctors don't relate it. The disease can happen after the implantation because we don't have symptoms in the mouth. So here we have the T lymphocytes activated. Just an example, that patient of mine with titanium implants and that tissue reaction. After this, she told me that I already have the other metals reactions, but is everything fine in mouth, in her mouth? So we have that potential cause of titanium particles, and you release an implant dentistry. You have a lot of articles related to this also. Allergical contact dermatitis caused by titanium screws and dental screws. I already see, like this case, the huge layer of oxides surround the implant, and we have that kind of bone loss. And I switch the implant, remove the titanium implant, and insert the Zirconia implant. We have a lot of articles after, and at least 10 years, talk about titanium allergy. But here we have to consider the hypersensibility type 4. And the osteoimmunology drives the dental implant osseointegration when we consider that kind of alterations. So for patients with metal allergies, there are alternative materials such as ceramics that can be used to avoid potential allergic reactions or immune reactions. These materials are also an option for those individuals who care about the aesthetics or don't want to see the visible metal and their dental restorations. Moreover, frequently used dental implants. So when you see about the zirconia, we see articles talk about the more friendly with the tissues. We have the more adhesion proliferation behavior of the immunogingival fibroblasts. It's really good to see. We have that biological interference, and we have a strong adherence of the cells in the zirconia implants, and you can see. And the other, we can see the evident bacterial dome migration and titanium. Titanium is more aggressive for the tissues. We have a lot of articles talk about the tissue affinity, the interactions and the cellular response to zirconia implants. We have a lot of articles talking about the aesthetics of zirconia. And the zirconia have a strong soft tissue adherence. We have low bacterial peri-implantate tissue infiltration. We have a gain of keratinized gingiva. I hope I can show a case to you. We have no peri-implantitis and low mucosites here. We have a lot of articles. Here's more than 9 years to perspective with higher survival rate, 0 implant fractures, stable tissue with no periimplantitis, extremely good soft tissue response here. We have here article of Johan Lechner compare the titanium, and I think our meeting is lost. I don't know if I can show everything to you. Just a moment and let me finish here. So we have some kind of tests we can do to like MyLISA test and LTT test to check before insert the implant if our patients have some kind of lymphocyte reaction. That can be an alternative. Show you some case, because when we talk about zirconia, it's a very common, the dentists, oh, but zirconia, it's okay, zirconia osteointegrates, zirconia not a fracture, zirconia is resistant, what's the limitation? So I do titanium zirconia in my office, only zirconia nowadays. Here is a clinical case of anterior zirconia. It's really friendly anesthetics to the incisors, and I also use the zirconia, the Straumann implant here in that case to posterior area. That case it's already have 4-5 years. And it's fine. In the anterior areas, we have this Straumann 2 types of implants, the monotype implants and the 2-piece implants. And here we have only the problems with cementation. Is we have to deal with this properly. And we also use the two-piece implants, and here we can screw that crowns and remove whatever we want. So it's a good case. Here's another case with extraction and sinus lifting and 3 implants, zirconia implants with crown also in implants in zirconia. And here I talk a little more about the osteoimmune sustainability of these implants, considered the BIC, the bone to implant contact. In this article, Dr. Johan Lechner evaluated the osseointegration and osteomonology inside the implantology. And here he made an evaluation of bone marrow disease surround titanium and ceramic implants and compared these 2 types. And he made a conclusion that using the ultrasound cavital, the ultrasound to measure the bone density surrounding implants and measure that bone density and incomplete bone to implant contact at implants. And he finds the values of zirconia implants, ceramic implants, more than twice better surface of bone implant contact than the titanium implants. And also he found the values results, the BIC and osseointegration and titanium, and the higher expression of CCL5 surround the titanium group than compared to the zirconia. And just to put here an important point, if you never heard about cavitational osteonecrosis or bone marrow disease in jawbone, also known to fatty degenerative osteonecrosis in jawbone. Here is a really quickly definitions. Is a disorder of bone marrow ossification and mineralizations, who starts with autoimmune response So we have to consider if we have the inflammation with that our titanium implants or some kind of process, inflammatory process in mouth, who cannot heal properly and becomes the chronic bone congestion. And here we have the stressor or interference in other disease. So when you think only in allergic about titanium and not consider the immune reactions, even the bone marrow stem cells with chemokines and cytokines, that activation of lymphocytes, maybe you cannot understand what happened in some failures you have or the complaints your patients brings to you. So we have to consider that maybe we can have a lot of cases of BMDJ happen in our office. For example, when you start drilling to implant and fall up in the whole an empty space, that feeling of empty space, and you think, oh, it's a lower density, right, happen here. So that's a point of view to consider. This is another great case to the patent here to Dr. Sebastian Howard, and you can see that that friendly promotion to ceramic implants with the tissue, the soft tissues. Here we can see the formation, the increase of the soft tissues surround that crowns. That kind of thing, you know, don't happen when you use the titanium implants. So we have here a good material to use in our patients. Let me put, okay, the other ones is almost okay. Here is a difficulty when we talk about zirconia, is the rehabilitation. And here's an example for Dr. Howard also, that use an overdentary using a bar, a telescopic crowns here, using the ceramic implants patent also. So our conclusion. Here's two books, and the Portuguese books, and you have also the Cavitational Osteonecrosis in jawabone in English. You can buy online. And know more about the FJJ and osteoimmunology. So we can have here a little conclusion. Zirconia implants can be an alternative to our that 0.6% of patients who really have allergic reactions to titanium. So zirconia can be an alternative to patients with type 4 hypersensibility. You know, we have to consider it, our patients' complaints, individualize each case. Often the radiographic examination is perfect, but do not show the immune reaction into the medullary bone tissues. So maybe the complaints of your patients can be a reason when we consider the osteoimmunology, the immune reactions. And we have to consider also the immune system activation with chronic immune signaling as FJJ, and that kind of problems happens surround our titanium implants. Can be the failure of osseointegration, can be the failure of your implantation. So today I really remove a lot of titanium implants of my clinics for different reasons, for systemic reasons, for hypersensibility, for local pain, and I see the improve of healing in the health of my patients. So that becomes my reality right now, that I want to share with you. that may be for some part of the patients of the planet who need that kind of the approach, the immunological understanding of what happened with our patients. So I want to thank you for your attention. And here I leave my contacts, my email contacts and my Instagram contacts. And if you want the reference of this lecture, you just send me an email. And I'm glad to share with you these articles or books or whatever I can do to help you to get this approach, this another point of view inside our dentistry. Thank you very much.